drugs you see given for patients who have airway disease, whether it be asthma or COPD. So these are some of the symptoms that we're going to see in patients. Of course, dyspnea, wheezing, can happen with that chest tightness. But we also want to make sure that what is causing this problem, because we want those patients to avoid those things. We also want to make sure we understand, do they know how to take their medication? Because one of the things that's kind of crazy about this and why people use the emergency room so much is that if you did a peak flow, you'd actually be able to increase your medication without going to the hospital, right? So doctors work out with you if you have respiratory problems. Instead of using your medication every 6 hours, when you blow yellow, you know, because Dr. Caution said in your peak flow, then I want you to actually use your medication every 4 hours. So see, you can get a person, I want you to still come see me in the office, but I can kind of control your symptoms where if I see you in the office, that's a $300 visit as opposed to $6,000 if you go to the emergency room. So we want to make sure. Plus, of course, you know when we go to the emergency room, we have everybody's floor that you're exposed to. So we want to try to keep them doing that. And then, of course, we want to determine if patients need ventilator support. When you got a person who you can tell is just tired, you need to intubate them sooner than later. Don't let them just keep doing it, because that's a horrible thing to watch for patients. And with asthmatic patients, if they get quiet, is an ominous thing, because they're not moving in. So we're going to monitor patients for their O2 saturations and mental status, all those things that go along with that. Monitoring breath sounds, and then of course you want to educate about the peak flow. That's one of the things that we can do. You know, it's not that it's going to prevent the disease from happening, but we can prevent you from being hospitalized from it. And we go more proactive in trying to alleviate your symptoms. So another thing that we can see associated with pulmonary problems is TB. TB was also something we thought we got rid of years ago until HIV. Then we saw this insurgence of TB cases. Now the issue that we have with TB now is because most of the strands that exist now are multi-resistant. So that there used to be a time when you were a nurse who was exposed to a patient who had TB, you only had to take one drug. But now you have to take multiple drugs too, just like a patient who was positive for TB. Now, you look at your patients here, most of the time you look at NCLEX questions, they're talking about pulmonary tuberculosis, but TB can be anywhere, your bladder, your bones, all this kind of stuff. So that's miliary TB when we talk about that. But most of the time you see they're talking about pulmonary. So these are your risk factors, that immunocompromised patients, so that's why we saw with HIV. We also see a disproportion in poor individuals, people who are in institutions, that kind of thing. So even if you're not a prisoner yourself, working there can end up being problematic for you. So these are the signs and symptoms we see with TB. One that is not up here, which I don't know why it's not there, is hemoptysis. Because if you have a patient who has bloody sputum, unless you know they have cancer where they could have a lesion where there should be blood there, you need to have them evaluated for TB. And part of that is when the tubercle opens, that's when you get the bloody sputum. So that's why you want to have that. Usually patients have a temp in the afternoon, night sweats, losing weight, and not trying. Because one of the things in life, we all know, now we have Wegovy and all that kind of stuff going on. But, Ozempic too, you know, all that same medication. But when you have a person that's losing weight and not trying, you look for bad stuff. It's never anything nice. Because we know how hard it is to lose weight. So when you have people that are losing weight and not trying, you start looking for, is it TB, is it cancer? Those are usually the things that we end up finding. But these are the things that we will see in a patient. And so diagnosis is made. Actually, we can do skin testing, but most nowadays you'll see doctors are tending more to do blood testing. And the reason for that is I don't have to wait for you to come back for me to read it. Or you forget and then doesn't come back for me to read your test. So we have quantiferon testing that we can do for that. This is one of those that does not, when you have a patient who has TB, your rights kind of go away. You know how we had all this craziness in our state about COVID, about who can do what and all that kind of stuff? Well, TB kind of trumps all of that. If you have TB, I can lock you up if you're not compliant with medications. Because the health of everyone supersedes your personal rights when you're talking about TB. So a lot of times we do have patients who are indigent, And know that we have what we call witness therapy, meaning that I can set it up for you at a soup kitchen. You only have to come twice a week and take your meds. If we can do that, fine, but if that person's not gonna comply, I can actually make you go to a place and have to go treatment. This is a negative airflow, of course, and we're using a HEPA mask when you go in the room. Patient, when they come out of the room, has to wear a regular mask. You wanna make sure anything they cough up, you wanna make sure they dispose of it properly. So I give them a whole box of, several boxes of tissue. I give them several bags in there so that you can dispose of anything that you're coughing up out of there. Now, of course, medication is key to treating these patients. Like I said before, you only have to take, if you were exposed to somebody who had positive TB test, then INH was the only thing you had to take. But now it's gonna be, at least when you look at your drug therapies here, 4 drug therapy for everybody. What they'll do is test, you'll be tested, but they're gonna give you the medication as well. People who take medications for TB, you notice that most of your side effects have to do with your liver and your kidneys. So you have to worry about what the kidney function is like, what liver function is like. You get rid of any medication that this person takes that is bad on the liver. So you get away from Tylenol. If they're on statin drugs for their cholesterol, you have to take them off. All those things have to go away until this therapy is done. So rifampin turns everything orange, so you have to make sure patients understand that. You look at this, glowing urine and go like, oh my God, what's wrong? Know that yes, it's gonna turn everything that way. And if they're a person that wears contact lenses, you tell them to just get rid of your contact lenses till your therapy is over. Because it turns your tears orange. So that means it's gonna stain contacts, so it's just wasting your money if you're doing that. So you just talk to patients about that. But the numbness and tingling that you have sometimes associated with INH, you can get rid of by taking B12. So you'll see people, with all different types of things, but I will tell you that some of these resistant forms are killers. And I know that Michael Jackson was crazy in a whole lot of things, but he used to wear a mask way before we started doing it. And there was a story one time on 60 Minutes about a patient who got out of a Russian prison and got on a plane and flew to the United States. And when he got off the plane, he was so sick, they took him to the hospital and found out he had TB. So then they had to now go and talk to, even though that, because the plane, your air on the plane is recycled. So then you start gagging, right? Everything related to this person has TB. So this person was sick. He was in a first class seat, which was nice for him, but he was still coughing and sick. He converted 14 people on that plane. Wow. Because when they went back and they looked at all the patients or people that were on there, when they tracked them down to test them, 14 people had converted to positive skin tests. So they were all treated for TB. So just let you know, don't have it. I know people got like take the mask off after COVID, but when I ride on a plane now, I always have a mask on. I don't care. But after COVID, that was one of those things. And I remember I was in the Tennessee airport and the lady asked me why I had on the mask. I said, if it was your business, you would know. Why are you asking something like this? People got nerve. I mean, the stuff they ask you sometimes, you're like, really? You don't be like that? Yeah. So the RN is prepared to administer. I'm sorry, I'm crazy. I should tell y'all it's bad like me. So the RN is prepared to administer PPE tests to a client who is entering nursing school, which actually by the RN has the highest priority. So what's the most important thing we're thinking about with the skin test? Is it preparing the solution, assessing the skin condition on the forearm, teach the client about positive findings, or inquire about Bacillus Calmette-Guerin vaccine history? Number 4, because this is a person who's going to test positive, so you're just wasting time giving them a skin test. They're actually going to need an X-ray. So then pulmonary embolus is one of those things that when you have patients, part of why you see our admissions in the hospital nowadays is that they talk about GI prophylaxis and DVT prophylaxis, because this is the end result that you can have with patients who have that DVT or that venous thrombosis. And that becomes embolic, and so you see this happen in the patient. Now the thing about pulmonary embolus is that you can have a patient who is symptomatic or asymptomatic, because if it's a small emboli or if there are small little ones, you may have a person who's slightly short of breath, all the way up to somebody when you take out a whole pulmonary artery or the whole the lung itself, then you're going to have a person who's very symptomatic to somebody who's totally out of it. So you can have symptoms vary with the patient. So these are your people at risk. Prolonged immobility, anybody who puts in a central catheter, obesity, malignancy. Like I said, we don't know why that cancer diagnosis is that, but that's a more risk for a patient to have some type of thrombus. We also know that clotting disorders, of course, are going to put the person at risk. But one of the things about patients who have a history of thromboembolism, once you have one, you're more apt to have others. So that puts them at risk. You already have that as CSI in your brain, and that can happen with your patients. So then, of course, we have smoking, birth control pills, and pregnancy. And when you have a person who smokes and take birth control pills, you know, it's bad enough we talk about cancer at 300, but this one is a 500% increase in people who smoke and take birth control pills who are at risk for having thrombus. So that is not something you want to do, right? So you want to have those people. And I have some people, well, what if you're doing that, what, the vaping thing? I said, you're still gonna die. You're trying to get one thing for another. You always ask me some crazy thing like that. I said, we only know a little bit about vaping so far, but what we don't know about it is not good. You know, it's not that cancer risk, but it's other stuff that is happening that's changing your lung tissue. A lot of fibrotic stuff is happening with people's lungs who do vaping. And then, of course, we see it elevated in heart failure. So with this one, like I said, you can have a person who is extremely dyspneic, or you may have a person who's slightly short of breath. It just goes the gamut when you're talking about these patients. They may have a stabbing pain in their chest, some crackles in their lungs, changes in their heart sounds. You may also have a patient who has hemoptysis here, and this is from infarct here, when you have a death of tissue, but it's usually a streak of blood. It's usually not a lot like you see in a patient who has TB. But one of the things that is crazy is that feeling of impending doom. And I know that sounds like, I went to a place one time and taught a class where it's all Latina students from all over different places, because they have a campus up here, Ana Mendez. So I had Spanish people from all over, and the student said, what is that? And I'm going like, you know what that is? But then you think about it, but she said there's no translation for that in the language. So I said, well, it's like you're gonna die. You know, because I said, but the patient feels that. And if you ever have a patient who has it, you'll never forget it, because it does happen. Sometime in your life, you're gonna get a patient. Now I'm always gonna die, because you hear me dying with my trach all the time. Right, so I'm gonna die, but there's something about this when you go in the room and the patient tells you something is wrong, I feel like I'm gonna die. The look on their face lets you know that it's real. And you also, sometimes the hair on your neck sticks up, you go like, oh my God, we gotta get this person out of here. So it's happened to me a couple of times in life. One of them, and the big one, where we had one person actually died. This guy lived. It was a guy who was a trash person, and he had stepped down on something where he was at work, and it was something sharp, and it went up through his boot. And so he had an avulsion fracture of his great toe. So that means that you had a fracture from something you just, you know, because you stepped down hard. And so this is what he had. So of course, he has all this pain and all this kind of thing down in the emergency room. They clean up his foot, and he comes up to the floor, and he's just chilling. What are we gonna do? You know, because I tell patients, this is what we plan to do with you tonight. This is what's gonna happen in the morning. This is, you know, kind of stuff. So we finally get him settled, because he's been in the emergency room most of the afternoon. We get him settled, probably about 11:15, 11:30. And then all of a sudden you hear him, you can hear, because he called on the bell, but he said, I need you to come because something is wrong. So I mean, his eyes big as saucers. And you go in there, and I said, what's the matter? He said, I can't breathe, I can't catch my breath. And so, you know, when you're doing that, you know, it's, for me, I know it's pulmonary embolus. He don't know what it is, but I'm going like, okay, the good thing is our interventional radiology person is there until 1 o'clock in the morning. So we get him ready, we take him downstairs. He has a huge pulmonary embolus that he has. They were able to go get it. They did an embolectomy that night. But that's the kind of thing, it's a feeling that a person gets that actually just comes out of nowhere, and it just, you know, but you know that something bad is happening. So that D-dimer test is still here, so that's something that you see with clotting. Now diagnosis, and even though they have VQ scan up here, and I know they tell you about it in the textbook, nobody does that anymore. The diagnostic test you're gonna see done is a spiral CT. That's gonna tell you that, yes, I see these clots for this patient, plus it's faster. VQ scans tell you probability. If you have a spiral CT, I see it. Now, if I had a patient like my young man, I don't even waste time doing a spiral CT. I send him to have a pulmonary arteriogram, because that's what he had. Basically what you do when you have an arteriogram is that I can actually go get the clot. So that's the arteriogram piece. I'm gonna let me see where it is, and then I can go get it. So that's what you usually see for those patients. Transesophageal echo is done to make sure there's no clot in the heart. So that's, if you have a patient who's had this for, it's been sitting there for a while, we don't know where it's coming from. Sometimes when they have a big old clot in the atrium, and so once they have, you get a coordinated effort with the heart or something like that, moving patients around, they have an emboli shower. That's what you end up seeing happen with those patients. So that's very bad. So what we try to do is prevent this. So those people at risk, we're doing things like putting on AV hose, using SCDs, those are things we can do. We're also going to be putting those patients on prophylactic antibiotic therapy, how to prevent them from having a clot. So that's why you see the patients taking the Lovenox, the Orixtras, those types of things that are going to try to prevent you from having a clot. We may also give the patients some antiplatelet drugs. That's going to be your Plavix, because that's antiplatelet. So those are things that patients can take as well. We want to teach them about how we cannot have this again, and also about stopping smoking. That's one of those important things, because smoking is a devil, I'm telling you, it does things to you. So we want patients to stop doing that. And then we have our acute management, that's our guy that went down to have embolectomy, so that's during arteriogram. But we also see patients who end up with a vena cava filter. And generally that's done, you know, textbooks will tell you they do it with the second clot. And pretty much that is the same. Usually when we have shunts put in, they do them the first one. But when you have a patient who has a vena cava filter, what it does is allow the clots to actually come up, but they're caught like by an umbrella. It's almost like a colander that holds the clot. And remember, clot's gonna break down over time. It has a process of lysis, so that allows it to break down without the clot actually going to the lungs. And they're gonna be on medication to keep you from having clots there as well. So these are high alert meds, so star these, or take a picture if you want. Likely gonna be on your NCLEX exam, because these are things that can cause bleeding. So if you can cause bleeding, can kill you. So that's why they're likely to see those on the exam. So anticoagulants stop new clots from forming or making that clot get bigger. Okay, now remember, thrombolytics dissolve clots. Anticoagulants stop new clots from forming. And if I give a patient a thrombolytic drug, they're also on anticoagulation. Because yes, I'm gonna get rid of this clot, but you're still apt to clot. So yes, the patient can be on both drugs at the same time. Because that's also sometimes they ask you on a HESI exam, can you give this patient both meds? Yes, you can. They clot, your body clots on 16 different pathways, so I need to find, what I'm trying to do is achieve anticoagulation on one. So warfarin, of course, our Coumadin for our patients, started within 3 days of heparinization. So that's telling the patients on heparin, I can achieve anticoagulation within hours with that. But it takes days for the Coumadin to kick in to where it's therapeutic and I can get rid of heparin. So that's why patients can be on both drugs. Low molecular weight heparin, which is Lovenox, enoxaparin, that you can give to patients, gets rid of some of the side effects that go along with heparin therapy. But remember, Lovenox is something that's general. When you send patients home about 10 to 14 days, patients can take injections of Lovenox. When you see people in the hospital with all that bruising all over their abdomen, it's because people don't take the time to make sure the air bubble is on top. Right? And when people tell you they have a lot of pain with their Lovenox injection, it's because the air bubble isn't on top. So when you turn that syringe over, make sure all your air is on top. That sends it deep sub-Q. Patients have less of those problems, less pain associated with it. Because I have given it with students and they tell their patient, you know, y'all are nervous. It's just like a dart. That's what you're gonna do. But when they give the shot, the patient goes, that's the best shot. Because y'all do it right when somebody's watching you. All right, so nurses don't take that, you know, sometimes make sure that bubble is there, so we want to do that. And what's funny about Lovenox is one molecule different from heparin. That's all. But the cost is $5, $450. So it's only one molecule different from heparin. All right, so when we have our clot busters, our fibrinolytic drugs, our thrombolytic drugs, is that next slide. All of those end in ASE, streptokinase, urokinase. So you know those are our clot busters that we have for patients. So we want to make we're looking at our APTT. Now remember I told you that heparin, when you have a patient who's on it continuously, we do the activated partial thromboplastin time. So that's why that little A, PTT, that's more accurate for a patient who's getting heparin. So you want it 1.5 to 2.5 times your control. which means that if I have a patient on heparin and the normal PTT result is 40, 1.5 times 40 is 60, 2.5 times 40 is 90, so that my therapeutic range is 60 to 90. This is the one time you want lab work to be abnormal, is during anticoagulation. Because if it's normal, the patient isn't anticoagulated. Okay, so you want it 1.5 to 2.5 times what your control is. All right, so both of those are high alert meds, so this is why you might see them again on your NCLEX exam or on your HESI exam, because there are things that even if I use them right can kill folk. Okay, so I want you to make sure you know about those. So then we have our anemias, and like I think I talked about it yesterday, iron deficiency anemia is the most common type. So in your NCLEX questions, I'm not saying that you're gonna get a lot about this. Anemia is common, but it's not like a priority thing. So you may see a question on it, you may not. But iron deficiency anemia is the most common. So think about what's happening with the patient. Iron deficiency is more common in children, in older people, and pregnant women. B12 deficiency is for anybody who has any GI problems, because you need intrinsic factor, which is made in the GI tract. That's the person you worry about. We have a new class of anemia that's happening more often, and that's from chronic disease. So when you're not giving blood flow to your kidneys, not only does it not produce urine, what else does it not produce? Erythropoietin, right? So if your kidneys are not functioning well, you don't produce erythropoietin, which then affects your bone marrow to produce RBCs. So now you know why all your chronic renal failure patients are anemic, right? So it's always a reason. Always think back to A&P that will help you answer questions. So there give you some other reasons why your patient may have a low red blood cell count. But then think about what those cells do, helps you figure out what you're doing with your assessment of your patient. RBCs are what carry, or the hemic portion carries your oxygen. So if you got a person who has a low H&H or a low RBCs, they're gonna be tired all the time, tachycardic, they're gonna be short, with any type of activity, they're gonna feel bad. Now the majority of people who have anemia, you kind of live with it. You go like, oh yeah, I'm anemic. Or they don't know yet, they just think they're getting tired from doing stuff. And finally, their hemoglobin can be like 5, and then they're so pale, they look like a bed sheet. Or they're so tired till somebody says, you need to go see somebody. And then you find out their hemoglobin is that low. Because most people just put it off, I'm feeling tired. And then until you get lab work done, then we see this is happening with you. So these are some other things that we look at as far as the diagnosis, hemoglobin less than 10. That's why I told you to think about 10 to 14 for your lab value there. You treat the underlying cause. Now, if you see up there, they say to Epigen Alpha for iron deficiency anemia, it is never first-line therapy. Iron tablets are. The main reason is Epigen is expensive. It's like $500 a vial. So it's never gonna be first-line therapy. Nobody's gonna do that. They're gonna tell you to take iron tablets and eat better. And then if it's not, then we're gonna give you that. But you do see it used for dialysis patients because they actually need it. Iron's not gonna change much for them if they're taking iron tablets. All right, so if we administer blood products as prescribed, if patients do need that, and then you're gonna tell them about how you change their diet to hopefully improve the precursors of making RBCs. So the charge nurse is planning client assignments for the unit. The collaborative care team consists of an RN, a PN, and an unlicensed assisted personnel. Which client will be assigned to the RN? So we know the RN is gonna get the most serious patients or somebody having a problem. All right, so we select all that apply. Thing of the devil. So we have a client awaiting blood transfusion for GI bleeding with a hemoglobin of 7. A client with pernicious anemia who is awaiting a vitamin B12 injection. A client with resolving sickle cell crisis awaiting IV fluid conversion to saline lock. A client with a pressure ulcer who has been prescribed negative pressure wound or vacuum assisted closure or VAC care. A client who received two blood transfusions yesterday and is awaiting morning care. 1 and 3. Even though 3 is just converting something to a saline lock, in NCLEX world, PNs cannot do anything with IVs. That is crazy as heck. But in the NCLEX question, that's what you have to think about. Okay. So blood transfusion and then converting that IV to a saline lock. So blood transfusion is of course something that may be on your NCLEX exam. It remains in the top 10 med errors every single year about giving patients blood products. And it's not that it's such a big skill, it's that we miss one of those steps in making sure that it's for the right patient. Is usually what the problem is. For patients who are, long time ago, you know, when dinosaurs roamed the earth and I started working as a nurse, is that when a patient was signed into the hospital for treatment, that covered blood products. That no longer does that. So every time you have to transfuse a patient, or every episode requires a different consent form. So say that I had to give a transfusion I would type across the patient because their hemoglobin is 6. So you know we don't transfuse unless it's less than 7. So type across this patient for 4 units of blood, and then I tell you to transfuse 2 of those, right? So I'm gonna give that blood product today. Tomorrow morning I check their hemoglobin, it's still low, I can give those other 2 units. So that one consent form covers that. Now 2 days after that, I'm looking at this person's lab work, their hemoglobin has gone down again. Requires a separate consent form. It also requires another type and cross. Every time you give a patient a blood product, they create antibodies to the blood. So you will have sometimes when you're giving patients, sickle cell patients, cancer patients, anybody that gets a lot of transfusions, sometimes you're waiting for blood products for days, right? So young, healthy people like you with no problem, I'm usually ready to give you blood in 2 hours. Because the blood bank has that ready, unless you have some crazy thing going on. But if you keep giving people blood products, you create antibodies to it. So I have to keep trying to make sure you don't have a problem with this blood product. So sometimes, even though the doctor writes the order, it's 3 days before you're actually giving blood to that patient. It's not everybody, but it would be some of those patients that you deal with. So that means you have to let the doctor know. They want to say you're delaying treatment, all this kind of stuff. You only do what you can do. The other thing which I didn't talk about when we talk about cancer, if you have a patient that they are going to do a bone marrow on, they try never to give that patient a blood product. It is much easier to find a bone marrow match when you don't have antibodies. So if I give you blood, you are creating antibodies. So they try to, unless you absolutely have to, give a blood product to somebody who needs a bone marrow. So the one thing about this, and I know it's all stuff is up there, if I have to give blood product to a patient, I take care of all my other patients first. Because the majority of people who have reactions to blood have it in the first 15 minutes. So take care of your other folk, but make sure you have a good IV site. All this you want to make sure ahead of time. I have a good IV site that I can use, because if you have to restart the IV and you don't get it in, blood can only stay out of the blood bank for about 15 to 20 minutes depending on your hospital. So if you get it up there and I don't have a site, and then it's blood can only stay out for 4 hours, and it's 3 hours before somebody can start an IV, that's a wasted unit of blood. So make sure you have a good IV site for that patient as well. Normal saline, the only thing that can run with blood products, right? And then tubing can only hang for 4 hours. So if you have to give 2 units, now I'm telling you, with old people like me, you better be going close to 3. I don't have a lot of stuff wrong with me, but the older a person is, they need the cells, not the volume. You can put people in the heart failure. Add a hand.
If you give blood too fast, like they started in the ED and they give it too fast and the patient starts having a reaction, is that a real reaction, or is that just because they gave it too fast?
Now, if you're giving it that fast that you have, now see, and if you got a trauma patient, sometimes you put a pressure bag on. So it depends on what's going on with the person. So if you're a trauma patient, we put a bag on it, it's a pressure bag, and so we're giving it fast. But those are people who are bleeding out.
It was a young person that just came in with really low hemoglobin.
Yeah, you shouldn't be giving your blood that quick, still.
They did, but so she had a reaction, it was a whole big thing, but then she didn't want any more blood,
Exactly.
She needed it.
So you try to kill her.
Was that, was that a real reaction, or was it because?
It's probably, I mean, it's more than likely, if she did, this is the thing. Most of when you look at your reactions here about what's happening with patients, like I said, the majority happen in the first 15 minutes. If you're talking about somebody that gave a lot of stuff quickly, she feels, I mean, the patients, even though you go like, oh, the blood is going in, but your body feels like, oh my gosh, all this stuff is here now, so this is what's happening. And so you may have a person, like I said, that needs those cells, but when you're talking about volume on a patient, that's like, oh my gosh, I have not just the cells, but you added another 2 liters on top of that. So if you're giving that to a person who may, and the thing is not knowing what her history is. You know, you gotta think about if this is a person who has some kind of heart problem or this kind of thing, you run the risk of putting that person into congestive failure, or, you know, if they're not short of breath now, they're gonna be shortly. And what type of reaction did they have? If you get, most people, like I said, will have that reaction within the first 15 minutes, and sometimes it's a temp, that's the febrile reaction. So that's why you need to know your vitals before you pick up blood. If you got a person who's hives, urticaria, you know, anaphylaxis, that kind of stuff, you have those type of reactions too. But the majority of people that we see, I mean, especially the older ones, it's fluid overload. And it's because they have a history of heart disease, kidney disease, this kind of stuff. And when if you had a young person with a low hemoglobin, if she's a childbearer, the first thing I ask her, you know, are you having heavy menstrual periods? And so that's somebody that, yeah, I want to give you a blood product, but I don't need, still, in my head, you give it 2 hours. That's the way I look at it. If at the least amount, an hour and a half. I never give anybody blood faster than that unless it's a trauma patient. That's just a rule kind of thing. Because your blood tubing can hang for 4 hours, so I can give 2 units. Or if I don't need to just pour it into a patient. If they're not bleeding profusely, you don't need to pour it into a patient. And if you're doing that, because sometimes, especially with trauma patients, you use reperfusers. So if I have a person with a chest wound or something, so I put in a chest tube that allows me whatever's draining out, I can put back in the patient. Those are the, you know, but that's that person's own blood, right? When you're doing a reperfuser. But then I may also be putting blood in them in a pressure bag, that kind of thing. So a lot of it will depend on what's going on with the patient. But that should I don't think anybody should ever get blood that quickly. That's reserved for those trauma patients. It's not for somebody that's injured with a low hemoglobin. So I'm telling you, you see some stuff sometimes, you wonder how people got a license in the first place. Because some of the things they do just make no sense about the outcomes for their patients. And that's one of those. And blood is a problem. Blood will help a person feel better, but it's not without cost, right? Because that's the issue that you have that goes along with it. So, and sometimes it's not the blood product itself, it's what it's preserved in. And you don't know that until you give a patient a transfusion. Because it's the citrates and stuff that are actually preserving the blood product that are the problem. So always make sure that it's 2 people to identify this patient, 2 licensed folk that are going to be needed to give this blood product. Like I said, I take care of everybody else and tell them that I'm going to be gone for a while. I need you to understand that. I get you straight first. And I always tell them that. I'm getting you straight because I need to go do something and I'm going to be away for a while. You let them know so they ain't bugging you. But then on top of that, you're able to give that attention to that patient when you start the blood product. Always let it start slow, about 50 cc's per hour. That first 15 minutes, I'm just sitting there talking to them, shooting the breeze. I say, let me know if you feel anything, feel anything untoward or that you're feeling bad. And they go like, what are you talking about? I say, I ain't telling you all that. I don't say it to them. But you know what, if you tell them what it's gonna be, they're gonna tell you everything you just told them, right? So that person who had, the reactions that you worry about, of course, anaphylaxis, but hemolytic is our worst one, other than that. And that's because when a patient has a hemolytic reaction, you're having an antigen-antibody reaction that destroys the kidneys. So you can put a patient into renal failure for life by giving them the wrong blood product. So that's why it's such a big deal. But what'll happen to that patient is they'll tell you, oh my gosh, my back starts hurting. Worry, because that's what happens. They have back pain, right? And if you had a person who was non-responsive and they had a Foley catheter, you can see their urine go from yellow. If you're gonna see that yellow urine they had before, then you're gonna see it go to apple juice, then you're gonna see it go to tea, and then it's gonna be bright red, because that's what you see in hemolytic reaction. That's the only reaction for blood that you also, because all your blood goes back to the blood bank when everybody has a reaction, but when a patient has a hemolytic reaction, you have to send a blood specimen and a urine specimen to the lab. All the other blood products, you just stop and send the blood back. But hemolytic reaction requires you to send blood and urine. Because we gotta see what the problem is. We gotta figure out what happened to the patient. Was it something at the bedside by identifying the patient? Or was it something that happened in the blood bank? But no, you don't have a lot of time to take that blood back. And we have a lot of blood wastage. That's why they're always, trying to get people to donate. But the major reason is you sometimes have people pick up 6 units at a time. And if you don't use them all, when you take them back to the blood bank, they're destroyed. They can't give them to anybody. So that's what the problem is. We don't want people doing that. So infuse slowly and then continue on. And like I said, but 4 hours is the maximum you want to hang your blood product. Now the ones that can go fast are fresh frozen plasma. That can just run you. That's not a problem for patients. Cryoprecipitate also there for the plasma components. But most of the time we give packed RBCs. That's what you're going to see given most often. Leukocyte poor blood is something that you see a lot given in oncology patients, because what we're trying to do is prevent them from having any reactions to that blood product. And then they also have a filter that will take that off. And if you ever had a patient who has a leukocyte poor filter, it just like is pulling teeth to transfuse the patient, because it has a filter that is very fine. If you don't fill it up, it gets air and your machine beeps all the time. So hopefully you never have to give a dose because it makes you crazy. All right? And our autologous is the person giving their own blood product. That's the person that knows they're going to have surgery, go donate. I know I'm going to come back in a month to have knee surgery, so that's my own blood product. That would be me. I ain't trying to get nothing from anybody. Right? So a client who's receiving a transfusion of packed red blood cells has an inflamed IV site, which action should the RN take? So what am I going to do? Positive focus question. Double check the blood type of the transfusion unit of blood with another nurse. Discontinue the transfusion and send the remaining blood and tubing to the lab. Immediately start a new IV site at another site and resume the transfusion at the new site, or continue to monitor the site for signs of infection and notify the healthcare provider. Number 3, all we have to do is just start a new IV. It's just saying inflamed, not saying a reaction. So we just have to get a new IV site. But remember, blood can only hang for 4 hours. So if you hung that blood unit for somebody that's older, has heart failure, renal failure, and I gave that blood in 3 hours, just know when you come and hang that next unit, just bring your new tubing. Just hang everything new. So now we're getting to some of the cardiovascular stuff, and some of these are going to be on your NCLEX exam or HISI exam because they're common, right? So we have hypertension, persistent elevation of blood pressure with a systolic greater than 90, systolic greater than 140, diastolic greater than 90. You know, the American Association of Cardiologists actually want to take this down. You know, normal blood pressure is 120/80. They actually want to make hypertension 126. So do you know how many people would now be hypertensive if we did that? Now that sounds like nothing, right? That sounds like nothing right now, but if you had to get insurance that was based on history, you would be screwed, right? Because the insurance company can say, I'm not going to insure you because you're hypertensive, because we know all this bad stuff is happening to you. Because just like diabetes, just a different pathology why it happens to your patient. All of the apathies that happen with diabetes also happen because of hypertension. You can lose your vision, your kidneys can be lost, you have a heart attack, you have stroke. All of that is end organ damage that happens with patients who have hypertension. So we get to a whole section now that have the same modifiable and non-modifiable risk factors. Every disease process we're going to talk about from now on fits the same one. So this is all stuff for your patient education. Lifestyle changes are things you want to do with that patient. So medications. Now, and when you think about cardiac stuff, it's 3 different buckets really, because students look at that sometimes and go, it's so many chapters that have to do with cardiac. You know, because 8 or 9 in a book, depending on how your book breaks them up. But it's 3 basic things that go wrong in the cardiovascular system. Volume, which hypertension is one. Hypertensive crisis, heart failure fit in that. Then you have structure, CAD. You know, we talk about vascular stuff that's going on with the patient. And electricity. Everything that happens to a patient fits into one of those categories, or sometimes 2 of them. But the thing about it is, that's what you have to think about. Stop thinking about every single one. They all fit together. And so you just have to think about what's happening with the patient. So if I have a volume issue, that's why diuretics are first. So potassium sparing diuretics is what we do. Now you will have people, because your textbook is going to say, try these lifestyle changes first, and then we'll put you on medication. It ain't nobody sending you home without a drug. And that's mainly because what is the hardest thing for people to change? Not just lifestyle, diet. People will do everything else you tell them. What you like to eat is what you like to eat. They look at you like, bye. I'm gonna eat this if I want to. So what is wrong with you? I'm gonna have Chick-fil-A every day, right? And now don't get me wrong, I love Chick-fil-A, but you know it's salty, right? So you notice the next day, shoes are little tighter, rings a little tighter, that's retaining fluid. You can't do that with a patient who's hypertensive because vascular volume increases, raises my blood pressure, right? So diuretics first, then they have antihypertensive, and when I see that, I'm like, what? There's a whole bunch of medicines that fit in that. So there's a lot of different drugs you have. And probably when you first started nursing school, you try to figure out why do we use this medication as opposed to this medication. It really does go back to research. Certain drugs work better for certain people. African Americans don't produce a lot of renin, so that's why calcium channel blockers work better for them, right? So ACE inhibitors work, pretty much for everyone, but some people have side effects that go along with them. Beta blockers tend to work better for Caucasian people. We make a choice about which medication we put the patient on based on that kind of stuff, research that tells you what you can do. So it's not just magical, we just do that. So even though they say lifestyle change, you're gonna go home on a drug. So hydrochlorothiazide usually first. If I don't get what I need from that, then I'm gonna put you on another medication. So ACE inhibitors, goes in Pril, like it is on Enclase, so you gotta know that generic name. Lisinopril is probably the one we use most often right now when you're talking about medications for patients. You know, that whole thing that's gonna lower your blood pressure, stop conversion of angiotensin 1 and angiotensin. Y'all know all that part. But the side effects are what sometimes keeps people off this medication. And that persistent, non-abating cough is one of those. But if I have a person that I want to put on an ACE, because it helps with the remodeling that happens with heart failure, I go to the cousin, angiotensin receptor blocker, who is the sartan. All right? Same effect that you have, it just covers your receptor site so it doesn't allow the attachment of angiotensin 1. So I can get the same effect of stopping that remodeling that happens in the heart, which is I need to have that person on that who has heart failure, but I get rid of the cough. All right, so Prils, sartans, I can use for those. Beta blockers are my OLOLs. So metoprolol, also known as Lopressor, is what we usually see when you're talking about management of those patients. Right? So now if we get into that and we're not able to control people on those dosages, then we start adding things like clonidine, apresoline, all that kind of stuff. But those are the big categories that you're gonna see. The calcium channel blocker is amlodipine, or Norvasc is what you see most often for that. All right? So why we need to do that, of course, and understand it is because number one cause of stroke is people not taking their blood pressure meds. And some of these medications cause erectile dysfunction. So those are the people when they come to the office don't want to talk to me. You can stick the finger at them, don't talk to me. About when that's not working, all right? But I'll tell a man any day, you'd rather do that than have a stroke and can't do anything, right? So we have to think about this. We can change your medications around, but we gotta control your blood pressure. So then we have coronary artery disease. I told you yesterday this was the moneymaker at the hospital. We have no end in sight of the patients that have this. One of the leading causes of morbidity and mortality. And the left anterior descending, or LAD, also known as the widowmaker, because it takes out most of your heart when a person has a heart attack, is the vessel most often affected. So when you hear the cath lab saying this patient had a 70% occlusion of the LAD, you're going like, oh my gosh, how's this person still alive? Right? Sometimes we have 100%. But there's a totally pathologic process that keeps some people alive, and they show it in your book. Collateral circulation is totally pathologic, but that's what saves your life. But they don't happen until you're old, right? So if you're 30 years old having a heart attack, that's why you die, because there's no blood supply around this area. When you're 70 and 80 years old, you have those little fingers going out there that get past that blood flow. So you sit down and chill. Yeah, you got chest pain, but you still here. 30-year-olds dead, right? So, but that's pathologic, but it saves you. All right, so think about a beaver building a dam. Beaver keeps coming there building stuff, but there's always a trickle of water. So that's what's happening when you have collaterals. There's always a trickle of blood supply that's going around the area of blockage. So one of the things that we do for patients is do C-reactive protein. It's an inflammatory response that we see, and it's elevated in patients who have their first cardiovascular event early in life. So it's now part of routine screening when you have your annual exams. So we have three different etiologies that we look at for this. Atherosclerosis, so that's a structural problem, have plaque formation. And one of the things that, I talk about the Chick-fil-A every day. If you have teenagers who are autopsied, you can already see fatty streaks. they start at that age because that's how we eat in this country, right? So you can start to see those fatty streaks early. But what happens is that plaque gets, thicker and thicker over time. Everything comes together, and then when you have an injury there, the platelets go, hey, I need to go help. So that creates the clot, cuts off blood supply. That's why the person has a heart attack. Then we have coronary vasospasm. These are people, when you do their cardiac cath, their coronaries are clear. But what happens is they're having spasms, which produce the constriction, which causes pain. Right? And when you see them, we do their cath, and they don't have, the doctor sends down, they only have a 10% occlusion. We have to put them on something that stops that spasm that they have. And calcium channel blockers are what does that. Then we have microvascular angina, and that's a small vessel disease. That's a person with end-stage cardiovascular disease. Not a whole lot you can do to save those people. We actually have a procedure, transmyocardial revascularization, that we do for these people. What the doctors do is go in and bore holes in the myocardium. So what they're doing is creating collaterals, but it takes about 4 months for that to work. And that particular procedure was first done in Tampa. Not first done in Tampa, I was just saying first done in the United States. It was a doctor from South America who discovered it, and he came to Tampa General to do it. So, but that's what you'll see done for patients sometimes. Tampa does some things right, not much, but sorry. So of course we gotta get our risk factors. What are we gonna teach those patients? So you want them to stop smoking, DASH diet, all that good stuff, and that's gonna go for every single thing you talk about cardiovascular stuff. Stress reduction is a joke, because that's just life, right? And then when you tell patients about exercise, tell them to exercise every day. The goal is to have a patient exercise 3 days a week, so if you tell them every day, you might get 3. All right, so that's what you want to do. So then, of course, diet was that thing we want to change, right? Because you see up there, if diet modification is unsuccessful, whatever, right? If you go to a doctor's office and you're low down, dirty lipoprotein, LDL, is high, you're going to be on medication, all right? So HDL is happy, so that helps you. But that LDL, that low down, dirty lipoprotein, that's how I remember it, is not the good one. So if I have a person with risk factors, I already put them on medication at 100. Because if I have a person who's hypertensive, you need to be on meds if your LDL is 100. If you're diabetic, you need to be on medication at 100. So now what you have, because high normal is 126. So now doctors just say, forget about it, put you on medication. All right? So the oldest one out there is simvastatin. Zocor was the first statin drug we had. Part of the 4S study that showed what do you do for a person after they have a heart attack so they're still alive a year later. And they're on the Holy Trilogy: aspirin, a beta blocker, and a statin drug. All right, so that's what you're going to see on a person after they have a heart attack. So it's the oldest one out there. Now I'm hypertensive. My cholesterol has never been high, but that old LDL was 101. So Agnes said, Sharon, what do you want? I said, well, if I have to risk my liver, like I drink. I said, if I have to risk my liver, I'm going to go on Crestor. And the only reason I take this, I don't have any stock in Crestor and all that kind of stuff, but it's the first drug that showed promise in treating amyloid plaques, which has to do with Alzheimer's. So I said, if I had to risk my liver, give me the medication that might keep me with some sense when I get a little bit older, right? So these all affect your liver. So you got to tell patients about getting rid of those things that if they have it take a lot of time on, you got to get rid of that. If they're drinking, you got to get rid of that. So we're going to do liver enzymes before we start them and periodically during the time they're taking medication. And the thing that we have, these other medicines here, Lopid is one that caused a lot of GI side effects, so people don't really like that. Nicotinic acid makes you feel like you're on fire. All right, so patients tell you, oh my God, you think it's a hot flash times 10. All right. Now, how you can get rid of some of that, because most of those people also take aspirin, right? So what you do is tell them, take your aspirin about 30 minutes before you take your niacin, because niacin is natural. It's a naturally occurring nutrient. So there's some people say, I'll take that because it's not a chemical drug kind of thing. So, but what you do is tell them 30 minutes before you take your niacin, take your aspirin, drink a lot of water, take your niacin, continue to drink a lot of water. It helps dampen that effect of that feeling like you're on fire. So you just help them out. Now the issue that we have, of course, is rhabdomyolysis. All right, this is where you have a breakdown of proteins, it's a big molecule that then causes liver failure, and then also will kill off your kidneys because the molecule from the muscle breakdown can't filter through your kidneys. So liver first, kidneys second. If you ever have a patient at rhabdo, they can never take a statin drug again. That's off limits to them at that point. Because it's a chemical thing that happens to the body, but you can't give that medication anymore. So then of course you have to do the DASH diet. Of course you want people to maintain their ideal body weight. But I told you, when you tell a patient that, when you tell a 300-pound patient they have to lose 150 pounds, you know you Charlie Brown. It's teaching. All right, Charlie Brown can talk, but the teacher always goes a little womp womp. Right? So patients, you don't realize sometimes you turn them off when you're saying that. So you just tell them 10%. 300 pounds, 10% is 30 pounds. Patient can see that. When they lose that, they only need to lose 27 the next time. So that's the kind of stuff you do when you're talking to patients to motivate them. Because otherwise they're just looking at your sideways. Girl, bye. Kind of thing. So we want that cholesterol intake down to less than 200 milligrams a day. And these are the manifestations of what happens because you have that blockage. And so we have angina. Of course, there's 3 different types that we look at here. Stable angina means I have a predictable pattern to my pain. So every time I make it to the 4th row, my foot goes down on that foot, oh, my pain comes. Predictable pattern. When I have unstable angina, and I'm sorry, it's usually relieved by rest as well. But because it's a mismatch between myocardial oxygen demand and supply when we're talking about angina. But when I have unstable, the predictability pattern goes away, and it may not be relieved by rest. So now I make it to the 1st step, or I make it to the 3rd step, or I make it to the 2nd step. There's no rhyme or reason now why my pain is coming. Then we have our patient who has Prince-Metal. This is the variant, or the vasospastic type. Usually doesn't have anything to do with activity. It can happen when you're dead asleep. So patient just wakes up talking about they have chest pain, but may also be from people that are smoking, a heavy meal that may produce that in the patients as well. So you may have some accompanying symptoms. So those are the things we start seeing in patients. Radiates down the arm to the shoulder, jaw, epigastric area, all things that are happening with patients. But then you may see some other things that happen with them. And always remember that there's going to be a need for blood supply that can't get there. Remember, the plaque is there, so blood can't get through. That's producing the pain, but then I also have some of these associated symptoms as well. So it's usually precipitated by exercise, cold exposure, heavy meal, sexual intercourse, stress. So sometimes we get these people early morning in the hospital, but also because they're taking Viagra, doesn't help, right? Since all the blood supply there is sent to my heart. So that's one of the things they always ask you about in those questions. All right, so when we talk about anginas, patients go on these medications. Now we talked about some of these before, but we just use them for a different reason now, right? So we have antiplatelet agents. So aspirin is the cheapest, but then we can also do Plavix, which is up there next for those patients. Usually if you have a patient who is coming in the hospital with chest pain, you tell them to chew aspirin, not take it, swallow it down. If you chew it, puts it in the bloodstream quicker, stops the platelets from coming together, making that clot bigger. So you also can have people chew Plavix. Now I don't know how chewing stuff is. I know anything that's not, I just think medication is wrong in a lot of ways. But a part of that was from being a kid in a house full of people. And so my parents, every time it got cold, you just lined up and everybody got colic over. Right? It's disgusting kind of thing. So I think everything that's liquid or you got to chew it is going to kill me. Even as an adult, I'm thinking the same thing. It's going to kill me dead, right? So, but one of the things that you do is that you have patients chew aspirin, and it's usually 2 aspirin you have them chew. And then if it's Plavix, they usually give them 300 before they take them to cath lab. So they get a lot more than they normally would get. And I always laugh about, because the thing about doing exercise, because the brother that is the engineer is also in his other life is a personal trainer. So he gets his body fat down to like 2%. I hate him so much. So he sends out pictures to people. I'm just like, I hate you, man. All right. And actually, he was hypertensive probably about 9, because that's family history. He was hypertensive about 9 years before I was. And he came to the house and was like, oh my God, I can't believe this. He's having a fit. And I can't believe I have hypertension because you're fat. I said, well, you're about to die, bro. So you won't have to have any of the complications. I'm gonna take you out right now. But he cracks me up with that exercise thing. But he's one of those that I always say with the reason I was talking about that was aspirin, because the thing that he'll tell, because it was a commercial on, you don't see it anymore. But remember that the male person, the exercise guy that was on The Biggest Loser? You know he had a heart attack. So this person exercises every day and does it for a living, but he still had a heart attack. So that's why I said exercise is the devil. Because you still die anyway, okay? But he's not, I mean, he's still alive, but that's what's his thing. He did a commercial for Bayer aspirin because they told him to chew 2 aspirin before he came to the hospital. And that's what saved his life, because he wasn't old enough, you know, he had some collateral, but not a lot. So I'm telling you that exercise is the devil. I don't know. But that's what I was thinking about when that aspirin was up there. The last one up here, the GP2D3A inhibitors, are things that are usually used for the cath lab. So that's not something you're going to get all the time. You won't get it out on the floor, but it's actually to stop what we call abrupt reclosure of the vessel. So it's something that's running through that. So integralin is one, persantine is one that goes through that. Beta blockers, of course, we talked about those, your OLOLs. They decrease myocardial oxygen demand, but you know beta blockers also slow heart rate, they lower your blood pressure. They protect the myocardium after a heart attack. So then we have nitrates, we know those are vasodilators. NCLEX questions, you always have to check vital signs before you give it. Because if I've got a low blood pressure, then morphine is where I'm gonna go for pain. All right, because I get 1 milligram of morphine, that's gonna help with the pain of the patient, gonna help with some vasodilatation, because that's what's gonna help that. But if your blood pressure is really low, I don't wanna give nitro, because that actually increases your heart rate, which makes your chest pain worse. So your calcium channel blockers help with that vasospastic form of angina. Because this may be related to a patient having a clot, thrombolytics may be there and anticoagulants. Remember, thrombolytics dissolve the clot. Your anticoagulants stop the new clots from forming or keep that clot from getting bigger. So yes, patient can be on both of those. Now with our ACE inhibitors, those are things that help us control blood pressure, because one of the things that we see over time is you're gonna see some vascular changes that happen because of blood pressure, so we're gonna give that as well. And then our analgesics, of course, relieve pain. Oxygen and nitroglycerin, both drugs we use here. We titrate oxygen to effect for a patient, but nitroglycerin, we know, we give sublingual, and nitroglycerin actually can be in a pill, spray, ointment, patch, and IV. It exists in every form that we can give it to a patient. So just know that you wanna check your blood pressure before. Every 5 minutes times 3, you're gonna give dose to make that patient sit down. One of the things that we change as far as education for patients is if you have a patient, because you know I give you the first nitro, you're sitting down, chest pain continues, and you put that second nitro over, that is when you should notify EMS. You don't wait till the 3rd nitro goes under your tongue. Because if you're sitting down and not doing anything, you're still having pain, then something may be happening with the plaque. All right, so this is just for my visual folk to think about if you want to take this picture about what the medications do for you. The other thing up here that it gives you is that even though when you look at a textbook, it will tell you that you can give your thrombolytic drugs 24 hours in that chest pain cycle, because that's actually written in literature that you can give it up to 24 hours. The goal is to give it within 6 hours of onset of chest pain, because always think time is tissue in the heart. The sooner I can give it to the patient, the better. If you're going beyond that 6 hours when a patient develops chest pain, you have to worry about the possibility of aneurysms, you know, all this kind of stuff that you really don't want to do. So I always teach patients, students this, and they'll look at it in textbook. I say, in real life, this is what we want to do. All right, so 6 hours or less of onset of chest pain, so it's always important to find out when the chest pain started in the patient. And the patient who gets thrombolytic, just right next to this, is going to be the patient who has a STEMI. Non-STEMI patients do not get thrombolytics. All right, so these are our interventions. So we have the PTCA, and this is your moneymaker, like I said, for the hospital. They go in and go up through the groin, go through the area, identify where the blockage is. They're gonna go through that, and if you just had a patient who had a plasty, like balloon angioplasty, that's what they'll tell you. Patient that had a plasty. People have plastic can go home the day of the procedure, unless they had a problem. People who have stents are always in the hospital at least overnight. So you go up in there, you're gonna push the plaque against the vessel walls to open it up. Most patients will get a stent, so you see that stent's gonna be left there to keep that vessel open. This is a person who's gonna go on antiplatelet therapy. If you have a stent, we have to keep that stent from clotting off, so you're gonna go on antiplatelet therapy. So we may have a patient who has a CABG, or coronary artery bypass grafting. So that can be done as an emergent procedure. So that means if something happened in the cath lab, because we have had people that go through an artery, they have to go emergent. Or you can have somebody have surgery that next day, or you may send a person home and then bring them back for surgery. Just depends on what's going on with the patient. So now acute MI is going to be on your test, common, right? So not on your HISI exam, for sure, you're going to see this on NCLEX. And this is because we have a death of tissue that happens, and mainly because it's related to coronary artery disease. If you look at this picture, up here it has a little arrow. This is where the patient had the blockage. So all of this tissue was ischemic. And then if you go a little bit farther, that's where you have injury. And if you look at this part right here, it looks dead. So that's necrosis, that's the infarcted tissue. I always think the farthest away is the tissue that dies. Okay? So, but all of that you're seeing happen with the patient. So there's some things that happen when a patient has chest pain. So ischemia, injury, infarct. So STIMI is the one you have to like mark for yourself that you're likely to see. They don't want, because even if you don't have history of being a cardiac nurse, you should be able to recognize what a STIMI looks like. So that's why you may see that on NCLEX. So non-STIMI is more common in women, and women, unfortunately, for a long time, they were sent home because they said they had GI problems, and they would give them something like Donagel and send them home, and their family found them dead the next day. They were having a heart attack. But now women have caught up with men in heart disease, so you don't see that as much. We treat them the same now. But there were years when we lost a lot of women because of that. So that's why we have a whole month now to talk about women in heart disease. So what we see with ischemia is T-wave inversion. Injury, we see ST elevation. Those are things to help you remember what you're seeing if they ask you a question, right? So ST, when we talk about T-wave inversion, that's something that you see associated with ischemia. ST elevation you see with injury. And actually when you look at a patient when they have ST elevation, and to say you have that is a person that has the ST segment greater than 30% higher, off the baseline. So it'll keep going higher. The more ischemia the patient has, it'll have what we call tombstones. Your teachers may have told you about that. It really does look like tombstones going across. And I always draw that in my classroom and I put RIP on that. Because if you don't reverse it, the person gonna die. That's what you're doing. You're talking about death of tissue happening in that patient. All right, so the major complications associated with patients who have an MI, dysrhythmia, of course, is number one. And the reason being is because when the heart is irritable, then it has ventricular dysrhythmia. And ventricular, I should say dysrhythmia, but ventricular are most common. The patients who have things like AFib after a heart attack is usually because it affects the RCA. The right coronary artery feeds the SA node, and that's why they end up with AFib. But the majority of your people will have ventricular dysfunction. All right. I'm sorry. So the other one is that you're going to have cardiac failure. So if it's a big old heart attack, the more leads that you have problems in, and that's one of the things to tell how big the heart attack is. It's not really the lab value of your troponin, it's how many leads you have changes in. Because that's telling you they're going to do different things in the heart. So that ends up telling you how big that heart attack is. Some of your other side effects are your other complications here. And if it's a real big heart attack, like if I have a person who has like a 6-lead chain or 6 lead changes, that's the person I worry about not only in heart failure, but cardiogenic shock. Because the pumping force of my heart is gone when I look at that for the patient. So these are your signs and symptoms, and remember that a person who's having a heart attack will have pain. If they're sitting down, laying down, standing on their head, pain just happens. So it's going to be a continual thing for them. You may get some slow, irregular pulse, and the thing about it is nobody ever thinks they're having a heart attack. Who's having one? So that's the problem that you have. People are in denial. That's not something that they're thinking they're having. So these are atypical. So kind of smart these, because this may be on your HISI exam or on your NCLEX exam, because some people do not present with symptoms like they're having a heart attack. Okay? So women, a lot of times, like I said, they think it's more like, it's not chest pain, I have this low pressure. You know, I feel like tired, this kind of stuff. That's what we see women sometimes complain about. The big one is in the middle, is your diabetic. You can have a diabetic having a huge heart attack. You see it on the monitor. They're sweating because they're diaphoretic, and they look at you like, what's the matter? It's because they don't feel it, right? Because they have neuropathy. And then if that person is already on a beta blocker, less feeling even, right? So you have that double whammy of they don't feel anything, but you see this big old heart attack happening, you go, you're anxious. They know something is wrong, but when they have neuropathy, this is the issue that you have with them. So they may not feel anything at all, but a huge heart attack is happening for this patient. But they have all the physical signs that go along with it. Now your elderly patients may have some confusion and dizziness, shortness of breath, but that diabetic one is sometimes they'll ask you the questions because that's a person who may be having a huge heart attack and nothing. Whereas me, you know I'm gonna complain about everything, right? So, and have a trait with it, you know? Right? So this is what you see, that's the ST elevation here. This is the ST segment, so you see how big that is off the baseline. That one's probably about 80%, 85% of the QRS complex. So that's a big ST elevation that you see happening with this patient. All right? So that tells you tissue death. I need to fix this. Still salvageable, but I can turn it around. Now, if you give a thrombolytic and it works, you're gonna see that go down. It's gonna look like the normal QRS complex. So if it works and it got through, it broke the clot, you're gonna see that. Patient may still have some discomfort, but you're gonna see that ST segment go down. Right, so they'll go back to what their normal sinus rhythm looks like or something, and they probably have PVCs or something with that because the heart is irritable. But that's what you want to happen. The goal is, or the core measure for acute MI is 90 minutes. In 90 minutes of presentation to an ER, you want to have the patient on O2, doing lab work, EKG. The EKG dictates what type of treatment you're going to give the patient. Right, so when you see that NCLEX question, which of these is the most important thing to do, and even though people go like oxygen is number one, when you got a person in the emergency room and oxygen is not written there, it's the EKG. Because EKG is going to tell you what type of heart attack they're having and if it's going to be amenable to treatment with a thrombolytic. Okay. So troponin stays positive the longest, 10 to 14 days when you talk about patients who have a troponin level. So that means that if I have somebody who comes in and, you know, because sometimes we have those, you know, can't think of anything that's going on right now. So the Olympics start tomorrow night. All right, so you were watching the opening thing of the Olympics and you were eating and you just thought you had some indigestion and like, okay, life is good. So then you come out, so that's like the 26th, I think it is. So then you think about what's, you are out, you know, if you talk about myoglobin, that's gonna be up and down within 36 hours. Okay, so that's gonna go up. You're gonna have the decrease in that numbers that comes back down to baseline. If you're talking about a patient who has your CKMB or creatinine kinase with myocardial bands, that's gonna be back to normal within 36 hours that you're thinking about what's happening with your patients. So then that means if somebody comes in next Friday, if I did those two tests, it would be normal. But troponin is still gonna be positive. So you can tell whether they have a heart attack, even, you know, move from that time. So that might be something to ask you on a question, either in your HESI exam or your NCLEX, because what test is gonna tell me for sure it was the heart, right? Because all those other ones will be back to normal. And remember that CK is marked myocardial bands for you, but CK can be elevated if you fell, when you're just talking about muscle for patients, all right? So y'all know what that means. You gotta walk about 15 minutes.